Welcome back to the Sports Medicine Project, Season 2, with Dr. Bradley Neal, one of the leading experts on patellofemoral pain. Man, this is a great episode. Two reasons. One, an expert coming to talk on one of the most common conditions that you'll see as a health professional, but having an expert run through the clinical recap with us and them also doing a clinical recap was unbelievable, unheard of, groundbreaking in the health podcast space.
That was really fun doing that. I feel like that just brought out conversations that you maybe wouldn't even think for us to ask to our guests, because it's maybe not as interesting of a topic, but it seemed to bring out a lot of interesting conversation.
Yeah, and we wanted to make the podcast more nuanced and ask some pretty tough questions, which Brad definitely had some great answers for. But to give you a summary of what we spoke about: patellofemoral pain biomechanics, evidence-based interventions, strategies for long-term management, the impact of anatomical variation, effective patient education, optimizing foot orthoses and footwear, what the research is on both of those, Gait retraining for pain relief, developing return to run protocols. That was fun, talking about treadmill, uphill versus flat running, exercise programming for symptom management, how to tailor your rehab dosages. Can we just get someone running and moving more, or do we need to do rehab? Do we need to do it forever? And exploring some of the cutting edge research in rehab, plus talking about some of the research that's coming up.
Yeah, it's definitely a podcast that I'm going to have to re-listen to, because there was a lot of new things that I hadn't really thought about before, or different approaches that I don't actually practice currently. So one that I want to re-listen to and then see if I can start to bring that into my own practice of patellofemoral pain.
Yeah, and doesn't the man have an analogy?
Oh, yeah, there was a good analogy in there.
I'm not going to give it away. I almost posted it on my Instagram story because I re-listened to the whole podcast, which I've started doing within a couple of days of recording it, just to see what I missed and what I thought that I heard, but reinterpreting again. I was like, damn, this guy's just got some crackers.
Some bangers.
I reckon either you listen to this podcast, and if you listen to all our guests, I mean, you have to be completely armed with so many analogies, but I don't know if it takes experience to develop them, or you hear them from someone else and then you just happen to translate them through speaking with people. But they are one of my favorite things in healthcare, because helping someone understand what I'm trying to say, that is like the basic principle of being a health professional. You can know all the research and the pain science and what exercise is good and how to do this foot orthotic, but the person in front of you understanding what's
They just need an analogy.
Yeah,
Analogy.
Yeah, and that's all it is, just breaking it down, that information, synthesizing it for them, and taking it in. Yeah, I just can't say that word. I was really struggling with that one. Synthesizing.
Yeah.
There we go.
Good job.
Yeah, good.
Nice.
So, yeah, now, if you don't know who Brad Neal is, you obviously live under a rock with no communication, because he's published a lot of papers, and we've got who he is and a link to his website and his socials below in the show notes. Plus, we have tried to, with the best of our ability, try to link all the papers that we mentioned. So you should be able to go down, because we had some people from last episode asking about those. But if you go down to the bottom, there will be the PMID or the DOI. And if you just copy and paste that into the internet, you will, voila, have a paper. Some of them are behind a paywall, but most of them will be open access, like Brad Neal's clinical guidelines paper. And that's one of the papers that we just find so much value in. Like, here is the clinical guidelines.
Follow that. That's all you need.
Yeah, there's some awesome stuff there. And it's translated for clinicians, which is great. I mean, I think some of the people that I see in the clinic would value in reading that. Dr. Brad Neal completed his MCS in 2011 at the University of Hertfordshire, definitely pronounced that wrong, and his Ph.D. in 2019 at Queen Mary University of London. I think that's where Ian teaches, but the focus was on lower-limb biomechanics and patellofemoral pain in runners. He spent a decade as a specialist musculoskeletal physiotherapist at Pure Sports Medicine, where he also served as head of research. Now, that part is really important, because as he mentions in the podcast, he's not currently seeing patients, back to back, day to day, but working as a clinician, bringing that clinical perspective in there. You can just tell when you speak to someone, like, yes, you have seen people and you have seen patients, because when we're speaking about the information, like, yeah, that's really cool, but this is how I'll explain it, or this is how it translates to the person in front of you. He says that all the time. So you just get that from an academic compared to a clinician or someone that's been a clinician for a long time.
Agreed.
Now, since 2021, he's been a lecturer in physiotherapy at the University of Essex and a postdoctoral research fellow in sports and exercise medicine at QMUL, while also teaching at the University
Queen Mary of University of London,
Hertfordshire. And he's published, as you would know, and below in the show notes, in journals like BJSM, and is an editorial advisor for several publications. His research focuses currently on patellofemoral pain, knee pathologies, biomechanics, and running-related injuries.
That's quite a bio, isn't it?
It's a bio, but when you've done this much, that's what happens. So enjoy this episode. Remember, the video component will be here. The chapters will be available, and you can just switch it to audio. It will also be on YouTube if you want to see our beautiful faces with some expressions. And if you are lucky, and you might have seen this in the last episode, which some of you did comment on, I do have a little bit of my inner thigh showing. So there might be a little bit of showing there if you want to get involved. But anyway, enjoy this episode with Dr. Bradley Neal.
Welcome back to the Sports Medicine Project. Now, it's been a little while since Blake and I have had the pleasure of interviewing someone because we've been on holidays actually over your neck of the woods, Brad. So it's nice to get back onto the mics and be able to, ask you some questions. So thank you so much for joining us. We're really excited for today's discussion.
No, my pleasure. Thanks for the invite. And I was told by a mutual friend that you were on holiday in the UK recently.
Was that someone that can put down a burger, or was that a different friend?
That could be someone that is very good at it. It's not just burgers. I can guarantee that whatever you put in front of him, he will eat it very, very quickly.
Yes, we'd heard the rumours, funnily enough, from multiple sources, and they were very much confirmed. So hugely great bloke.
Yeah, it's that classic Friends clip, I think, of when you were kids. If you didn't eat fast, you didn't eat, and it's never gone away.
For the listeners, would you be able to kind of introduce yourself and kind of give your background to how you got to where you are? Because I'm certainly sure most of our listeners will be familiar with your research around PFP, but tell us how you got there.
Yeah, of course. So I'm a physiotherapist by background, have been for coming up 20 years. I suppose my journey was relatively unique in that I went to university on a swim scholarship. And when I finished my bachelor's degree, I wasn't quite ready to stop swimming. So in order to keep my funding, I needed to keep studying. So rather than start another bachelor's degree that I was probably never going to finish, I managed to start a postgrad master's. But in order for that to work, I had to wait a couple of years to do any of the clinical modules. So the first modules I did were with postgrad research methods and then my master's research project. So I did a bit of research very early on in my postgrad career, which is probably what gave me the bug and kind of got me involved in research very early on in my qualified career. From there, I kind of did a few different things. I did some elite sport work. I did some work in our National Health Service, spent a fair amount of time in private practice, worked for 10 years at Pure Sports Medicine, which is London's biggest private sports medicine clinic. And having started up there, I met Dr. Christian Barton, who's from your neck of the woods, at La Trobe in Melbourne, got involved in a couple of projects, kind of that evolved into a Ph.D. and then as a postdoc continued blending clinical practice and academia before a couple of years ago I decided to give it a crack and become a full-time academic, which is what I'm currently doing now at the University of Essex.
That's an interesting development. It's funny listening to a lot of people speak. A lot of the time it comes from injuries and things that have inspired going down that pathway, but for you it's just the funding, just the pure selfish needs. I like it.
Yeah, and people always ask why patellofemoral pain, and I haven't got an exciting answer. It's not something that I've personally struggled with, or anything like that. I'd always had, despite coming from a swimming background, and I did my master's thesis on EMG of the swimming shoulder, but pretty quickly in my clinical career, probably because I spent a bit of time working in rugby, spent a bit of time working in football, lots of lower limb injuries. I naturally kind of gravitated towards the lower limb and then ended up doing a primarily lower limb caseload in private practice. Landed there, basically. Yeah, patellofemoral pain, I guess partly, the more I think about it, it must have been influenced a bit by Christian because that's his thing, right? But I did get the opportunity to get involved in a couple of different sort of international research meetings and stuff. And the patellofemoral group just always felt really collaborative, really friendly. It felt like a good fit. Whereas there are other areas in MSK research where there's perhaps not as much collaboration, and that didn't really click with me. So that's partly how I ended up with PFP, but it's not the most exciting story.
No, I think that's nice to hear, because I think I feel like being in a really nice environment makes everything that you're learning about and everything you're doing so much more exciting and enjoyable. And as you use the word collaborative, having that nice team culture makes all the difference in what you're doing and what you're enjoying each day as well. So, and I feel like it's something that's probably overlooked a lot of the time or not spoken about enough. So I think it's really nice to hear that, especially coming from an expert in the field.
Yeah, and I think part of it is because whilst research is always competitive, because we're all after research funding, right? The patellofemoral pain isn't a condition that afflicts elite athletes all that often. So unlike, say, tendinopathy or ACL injuries, for example, there's some money to be had even in the short term if you do something well for a period of time, which is why I think some of those areas aren't as collaborative as they could be. Whereas patellofemoral pain typically affects people like me, weekend warriors, recreational athletes, where, you're never going to be a millionaire treating those people, but it is a big public health problem. And I think that's where the collaborative nature comes from.
Yeah, it's funny. We had Christian on the podcast 5 episodes ago. Yeah,
That wasn't
yeah.
long ago.
We talked a little bit about patellofemoral pain, but a lot about running. But yeah, it was a great conversation. I see you got both your names on a lot of papers that I read.
Yeah, we've done a lot of work together. Christian supervised my PhD. Kind of halfway through, he went back to Australia, which is very selfish of him, but we managed to make it work. And then we've continued to do stuff since. Like we haven't done that much recently. Christian's kind of gravitated a bit more towards osteoarthritis, I guess, which is where most knee research goes ultimately, because it's kind of the end of the journey and then becomes particularly debilitating. But yeah, still good colleagues for sure.
Yeah. Now we wanted to speak about our weekly recap, and I never imagined in my clinical career that I would be seeing someone for patellofemoral pain. Then I'll be able to speak about that topic with someone as high a status as yourself, who published a lot of papers on that. But working as a podiatrist, very, very rarely does someone present to me as first-line therapist for patellofemoral pain. I'm either being referred for, foot orthoses, footwear, and, because I teach biomechanics, for some run assessment stuff. And a lot of the time when I'm seeing someone for the initial consult, and this is the case I'm referring to, my questioning is always around what they've done prior to that. So have you done a good loading program? Have you done some deload, reload? Have you optimized your run program? That kind of thing. And I had someone referred recently purely just for an off-the-shelf foot orthosis because there was a little bit of varus and, they had somewhat of a flexible flat foot. But speaking to them about what they'd done previously, they tried a bit of loading for a couple of weeks and it flared the knee up, so they stopped completely. And they hadn't done any loading for 4 weeks, basically took all the time off, and then started to run again and tried to go out for a 30-minute run, and the knee was sore. So they'd come to see me. They hadn't been back to see the other therapist. And they were basically like, great, I just want to get some foot orthoses to help out my knee. And of course, we know the things that they've done versions of the right thing, but they need to be a lot more diligent with good quality loading. It wasn't that running was bad. It was obviously just did too much too soon, and they had a big period of time off. And the clinical scenario for me was, I think in this case, I can't say purely based off your biomechanics that I know orthotics are going to be effective. And even if they are, it's not going to move the needle that much. There's no way on earth I'm going to put something in your shoe and you're not going to have any pain. This is purely a load capacity point of view. And I didn't end up prescribing a foot orthosis. I said, great, you need to go back to the first person that you saw and go through some loading stuff. And it's normal for exercises to flare things up. It doesn't mean it's wrong. You've just done too much. But reflecting in that scenario, do you think maybe I should have used foot orthoses in that case? Because it probably would have helped a little bit. And maybe there's a bit of buy-in and they thought they were coming. That's what they were coming to see me for. And my theory is it's just not going to really move the needle that much. Like, foot orthoses aren't going to be the magic wand for someone. And be interested to hear your opinion when you have seen them used or you've preferred for them, or what the research says. It's kind of a little bit of a grey area, but I mean, it's going to make them 5% better. That's not the main thing that they need.
Yeah, I think you've got a bit of an imposter syndrome there, mate, personally.
I was thinking that too.
Oh, really?
Yeah.
I say this all the time, if ever I do any kind of informal or formal postgrad teaching, to be fair, but informal postgrad teaching, I often say something to the effect of, and I'm particularly addressing the physiotherapists in the room, if you take away nothing from this other than that you should use orthoses more, I'm kind of like what we've done this weekend, right? But the evidence for orthoses in PFP is strong, and it has been for a long time, right? The number needed to treat, a statistic I really like for clinical discussions, the lower the number, the better, 1 being perfect. The number needed to treat for orthoses is about 4, right? It fluctuates a little bit, but it's low, and it's way lower than the number needed to treat for exercise. So what that effectively means is that if you see 4 patients with patellofemoral pain and you give them all orthoses, 1 in 4 will get better, right? If the number needed to treat is 8, 1 in 8 will get better. Kind of the higher the number, the worse the outcome. So you could hand orthoses out like Smarties to people with patellofemoral pain, and you've got a really good chance of getting a quarter of your caseload better. I think we can be better than that. I'm a big advocate of moving towards precision medicine and giving people the right intervention that aligns with them, and that's what our recent best practice guide is designed to try and steer clinicians towards doing. But I think this thought process that you mustn't use orthoses until other stuff's been done, I don't get behind that personally, because the evidence is about the same, right? You look at the Matthews trial from 2021, the biggest trial in the patellofemoral pain field at that point. Hip-based exercise and orthoses, the same, right? These interventions are effective and they are equivalent. The challenge is how to prescribe specific things to specific people, but I don't think we can stand behind the fact that orthoses need to come after other stuff, because the evidence suggests all these things are pretty similar.
Yeah, I like that. Maybe I think being a podiatrist, and I just, nothing makes me feel worse than just people thinking that. We just give out orthotics all the time, high plastic inner soles that are really expensive that don't work. And maybe I've swung a little bit too far the other way where, I'm not afraid to, but I'm like, no, we've got to do this first, or think about this, consider this, where, we could have easily used that and they could have got some relief potentially, starting them on some loading, and then they could have gone back and seen that other person and potentially had a better response with that other stuff that they're doing.
I think it's a balancing act, right? Because you don't want to practice in a manner that if all you hold is a hammer, everyone looks like a nail, right? Physio, I guess, is slightly different because we do slightly different things. We're a bit of a jack of all trades when it comes to intervention delivery, but I've got surgical colleagues that are obviously concerned that people think if they go and see them, all they're going to get is a surgical procedure. And same for physician colleagues, all they're going to get is a scan and some form of injection, right? Yeah. I think it's good to be judicious in your practice, but particularly when the evidence for your kind of main thing is so good, I wouldn't shy away from it.
Yeah, I did actually ask Ian last week around, are you aware, because I'm not aware of any research and I've listened to you speak around foot orthoses and custom versus prefab, but looking to subcategorize foot type and flexibility of the foot and seeing if people are having a better response potentially to, so they've got a flatter, more flexible foot versus a caver, stiffer foot, potentially orthoses may be more indicated or result in a better outcome. And I did read something in Rich Willie's trial that potentially having reduced foot mobility may, in quotation marks, increase the risk of developing PFP. Are you aware of anything with foot type subclassification and foot orthoses effectiveness?
It's kind of swung around a little bit. So if you look at some of the early work that came out of UQ, Cat Mills, Bill Vincenzino, etc., there was this thought process that a more mobile foot gave a greater potential for response, particularly measuring midfoot width with a simple set of calipers. That was tested in Mark Matthews' trial that came about 10 years later that looked to use that midfoot width as a stratification procedure. And whether you had high or low foot mobility didn't seem to predict whether you would have a positive response. So I think the jury's kind of out on exactly what foot type or structure, function, etc., is most likely to respond. I think the key bit of the custom versus prefab question is it lands somewhere in the middle, right? So if you look at all the trials that have been done in patellofemoral pain, most of them use Vasily devices because Vasily are pretty good as a company at handing out devices to research groups to test. So they're a prefabricated out of the bag device, right? But they're then customized for comfort. So initially people choose the stiffness of the device. Do you like a stiff device? Do you like a really flexible device? Do you like something in the middle? Once we've got that, okay, what style of device do you like? Is a full-length device most comfortable? Is a three-quarter device most comfortable? Once we're there, do you prefer a heel raise? How much varus posting do you feel most comfortable with? So they are prefabricated, but they're customized for comfort. So I think the customization question is less about the material relative to the cost, and more about what a participant feels comfortable with. And if you then go towards something more permanent, that's when, you know, if someone's really getting on with orthoses and finding them really beneficial, finding them really comfortable, struggling when they're not in there, well, then they might prefer to buy a single pair of permanent carbon fiber devices that are only going to need a top cover replacement, as opposed to spending $40-50 on a prefab every 12 weeks because they're significantly more perishable, right?
Yeah. And I've heard you say, which I really enjoyed on another podcast, around, you know, if someone uses them for a period of time, that they don't always have to be short term. If someone uses them, they take them out and potentially symptoms return, or they feel more comfortable, whatever potential risk that may expose them to, if anything, it's probably going to be a lot less than them not being physically active and moving and doing the things that they enjoy. So having a simple, customizable, comfortable inner isn't the end of the world, if it is for the long term, more than 12 weeks.
Yeah, and again, I think that's a big misnomer, because just because the studies have only followed up to 12 weeks or 24 weeks, you can't then assume what the long-term effects may be they positive or negative, just because trials haven't looked, right? And there's so many big thought processes around orthoses, like patients become addicted to them, they lead to weakness of the intrinsic and extrinsic foot musculature,
etc. The addiction is crazy.
etc. And big claims require big evidence. That's always my stance. So there may be times where short-term use is all that's required, right? One of my unique facts about me is that I play baseball. And a couple of years ago, I was really struggling with sesamoiditis on my right foot, because when you play as a catcher and you squat down on your toes for several hours on a Sunday, plus throwing, hitting, everything's going through your first ray, it got pretty sore. I used some devices that Ian made for me, first ray cutout, things settled down. I don't need them anymore, you know. But someone with patellofemoral pain, that where foot orthoses alongside footwear and alongside other stuff mitigates the load that goes through the knee, if someone feels like they need to be using them more long term and they're comfortable and they're not getting any secondary negatives, etc., don't really see why on earth you'd encourage someone to stop using them. That kind of has always felt a bit crazy to me, because we'd never say stop doing exercise, or we'd never say stop taking that drug if your system needs it long term. So yeah, I think we get pent up about what we consider to be passive interventions, but a passive intervention that leads to an active delivery, I think, is what we need to focus on, right? And the same is true for things like tape and donut braces and stuff. If that's all you're doing, you're probably a fairly crap clinician. But if you're doing it to help someone that's got a primary pain problem get over that bump, you know, my typical analogy for tape is it's like paracetamol for a headache. If your headache's bad enough, you take some paracetamol, things settle down. You don't then take paracetamol for the rest of your life, right? And taping is similar. Orthoses can be similar. They can be more long-term. It all depends on the person.
And so, Brad, we'd love to invite you into our weekly recap as well, with any interesting insights that you've had from this week that you'd like to share.
Yeah, of course. So we spoke offline, didn't we, about patellofemoral surgery, which isn't particularly common, at least here in the UK. It's becoming less common, and it's always a difficult decision as to when someone sort of has exhausted all of their conservative options and needs to go to something more invasive. I discussed a few cases a couple of weeks ago with a group over here that invited us in to do some specialist consults, and we were talking about situations where particularly people have got trochlear defects, and the literature doesn't back this up particularly well, but clinically trochlear defects are just always more troublesome than retropatellar defects. My reasoning has always been the patellofemoral joint is all about surface area, right? And the more surface area you have over which to bear load, generally speaking, the better your capacity will be, as much as I dislike that word because I don't think we have a good definition or ability to measure it. And I often say this to patients, you've got more articular cartilage on the back of your kneecap than anywhere else in your body. So if it wears away at an even rate across the entirety of your patella, we don't really mind, right? That's age and activity related change. Whereas if there's been some form of traumatic event or a particular exposure through a particular sport, particularly if you end up with a focal defect, particularly in the trochlea, that often becomes a low-level, grumbly, inflammatory knee that becomes very load intolerant. So on paper, there's good plausibility for a surgical procedure to be beneficial there. So if we kind of go back 10 years, everyone was looking at microfracture and drilling down into the subchondral bone to encourage some bleeding and some scar formation. There are now some grafts that can be used to plug these types of defects. And my clinical experience was always that they work pretty well in the tibiofemoral joint, but never seemed to do as well in the patellofemoral joint. And I always reasoned that to be in the tibiofemoral joint, there's always compression through a defect. Whatever procedure you have, there's direct compression down through the tibiofemoral joint, which helps that graft or that microfracture procedure take and kind of then provide a cover to the subchondral bone. Whereas in the patellofemoral joint, the primary force is shear, right? Particularly in early ranges of flexion. So whatever you've put in there, whether you've drilled it, whether you've plugged it, there's a high chance that shearing force will just lead to the defect struggling to take and become native. So we were talking about loading in particular ranges, and actually we're at the point where we think loading in deeper ranges is more likely to be beneficial, because the deeper into flexion you go, in theory, the greater the surface area. So you maximize the surface area within the patellofemoral joint, and then the primary force does start to become more one of compression than shear. So using things like deep ranges of leg press, even if you're just going from 90 degrees back to 60 degrees or something like that, or some form of 4-point kneeling exercise. My colleague Simon really likes to use bathroom scales under patients' hands, and the less load that's going through the scales, the more load you put in through your knee. So you can start off and you can visualize the scale and see how much more tolerant to load you're becoming as the number on the scales starts to drop down. But yeah, very much that learning point of don't be afraid of loading in deeper ranges, particularly if we're looking for compression. You know, it's not a bad thing, which clashes just so heavily with what I remember being taught about the patellofemoral joint when I was an undergrad. And I know we're going back more years than ever now, but you know, we do inner range quads and we stick a towel under the knee and we want to work from 0 to 30. And if anything, that's more likely to irritate than be beneficial.
That is super interesting, I find, because that's certainly the default. And a lot of I guess it's not even just going off what we feel, but I don't know if it's just a fear avoidance thing for a lot of patients to report they get nervous to sort of like crouch down or squat down lower, because that's the point in which they're worried that their knee is going to become more sore as well. So there's probably that sort of belief has like come across to myself in also thinking that must be the more painful position for them. So maybe that's something that we'd work towards a bit later on.
Yeah, definitely. And I think that those types of knees often have a catch or a pinch point, don't they? And if we think about being in a standing position, you've got to go through that pinch point to get into that deeper range. So I suspect as people start to go into loaded flexion, they go, oh, that hurts. And then their brain says, well, if you go further, it's going to hurt more. So they stop. When in actual fact, they may find if you go further, it's going to hurt less, but they never get there on their own. And then if, as clinicians, we kind of lean into that fear and don't encourage people into those ranges, then they're never going to get there. And again, I guess it kind of goes a little bit back to the orthoses conversation we were having as well, right? And there's still this stuff that exists within the knee. If you think about rehabbing ACLs, there are still lots of people out there that think open chain loading is something to be avoided because it increases strain on the graft. Well, actually, yeah, there's stacks of evidence now that suggests that that's not the case. I think clinicians avoid open chain loading for patellofemoral pain as well, because we look at the biomechanics literature and we know that patellofemoral joint stress is at its highest in those inner ranges as we go from kind of 45 to 0. So we avoid it. Well, actually, what's wrong with loading from 90 to 45 if someone can tolerate that? And if someone can tolerate going through a full arc in a knee extension, why wouldn't you use it? You know, the literature tells us that stress or joint stress, which is a composite measure of reaction force relative to surface area, is highest in a particular range. But if it's not leading to someone saying, ouch, you can get on with it. You know, I think at times we're more fearful than we need to be as clinicians.
What do you think, Brad, is the reason for that? Like you said, the literature is out there. There are plenty of podcasts. There's plenty of information about this. But if you do the same thing for 10 to 15 years, you assume that something would have changed or we would have learned something new. Like, do you think it's, you know, you're just stuck in the echo chamber and you can continue to do what you've always done and, you know, you do get results because lots of things can help?
Yeah, one of my many favourite sayings is, if you do what you've always done, then you'll get what you've always got, right? And you've got someone that's been a clinician for 10 years. Have they got 10 years experience, or have they got 1 year's experience 10 times over? You know, I think it's when you do what you guys do, you have your podcast, you value knowledge translation and learning. When you do what I do, you know, it's easy to think that everyone wants to continue to develop and evolve. But there's lots of people out there that don't, right? We impress it, or we try to impress this upon our undergraduate students. You know, I say to them regularly, we have a module called Developing Self and Others, and a big part of that is CPD and professional development. And I say regularly, if you want a career that's 9 to 5 or 8 to 4, and you don't think about it until you get to work in the morning, and you stop thinking about it the second you step out of your clinic or your hospital or wherever you're working, physio is just not going to be a good career for you, you know, because that's not how we work. You have to develop, you have to evolve, but just because we know it's important doesn't mean that everyone does it, right?
Kelly, you want to hit us with your...
Yeah, I'll be quick with my case. So I have a patient at the moment who was referred to me for chondromalacia patella. And I was just sort of reflecting on my explanation of chondromalacia to patella to the patient. I'd pretty much say the exact same thing that I would say for patellofemoral pain, with the addition of acknowledging their imaging findings, because that's often something that they're aware of, and that's why they've got this label that's been sort of stamped on them. So sort of just explaining to them that that's my interpretation of that is it's a softening of the cartilage around the knee joint. It's very likely that that's been going on for a lot longer than this 3-week period that you've currently got your symptoms for. Given the fact that there was a point where it wasn't painful previously, then there's a good chance we can get you there at some point down the track. There might be more of a reason why your knee's sore than mine, etc., etc. But yeah, I was sort of just wondering if there's anything else that you might change or add, or if you would do something completely different if that sort of scenario walked through your door.
Yeah, it's not a nice term, is it? Chondromalacia patelli, you know. Whilst words are in the ears of the beholder, I think it is a term that's got a kind of natural nocebic slant, and it often spooks patients. So I often approach it a bit like what we said before, which is that there is plenty of articular cartilage on the back of your kneecap. Cartilage can't cause pain. Cartilage doesn't have a good nerve supply, so its ability to tell your brain that something should be hurting isn't particularly good. Chondromalacia patelli very much refers to, as you said, Kelly, a softening of the cartilage, but chances are it's been there for a long time. It's age and activity related change. It's wrinkles on the inside. I'm often in a situation where I've got access to scans and things like that, and I'm reasonably okay at interpreting in the MRI as an example. So let's look at the rest of your scan. Whilst there is some change to your cartilage, the bone underneath, and bone does have a good ability to say ouch, appears to be fine. There's no bone marrow edema, there's no synovitis, the structure of your joint appears to be okay. We don't have too much to worry about here. But that doesn't mean that your experience of pain isn't real, and that's when we can start to move towards a thinking of this is an irritation, and we need to try and identify the source or sources of irritation. And over time, we will get you back to a status quo and then build you towards being able to tolerate more load without becoming irritated.
And then manage it very similarly to patellofemoral pain. Like when we talk about those studies that have been done in patellofemoral pain, does that encompass chondromalacia patelli as well, or is it a separate entity?
No, it's one and the same. So if we think about running a systematic search for a review, we would use chondromalacia patelli as one of our synonyms. Mm-hmm. So it is essentially one and the same. It is a term that, so if you look at the consensus documents that were produced after the last patellofemoral pain retreat, we are trying to discourage use of that term. It's a very radiographic term. Can we please say patellofemoral pain? What came out of our patient interviews was that patients find all of these terms confusing, and can we please just say kneecap pain, because that makes sense to them. They know what the kneecap is and they know what pain is. So we are discouraging its use, but it's probably not going to go away quickly, I wouldn't have thought.
Do you think that the broader diagnoses, if we call it patellofemoral pain or kneecap pain, do you think that diagnosis is coming from a younger clinician? Because Kelly and I were speaking about this, which we do all the time. We speak about work a lot in these cases, and we were having the discussion at dinner the other night, as you do, around the diagnosis and the broader diagnosis, because what we understand from the research, it probably doesn't matter too much if we can be clear on ruling out the red flags. We're going to treat it one and the same probably, and we can't be sure of the nociceptive tissue. But do you think coming from a younger clinician, it's a confidence thing, or perhaps patients don't interpret it as well? So, say someone like yourself saying, with your pedigree and the patients know who you are, like, yep, this is what is happening, this is what we think is happening, we're going to be able to load it and hopefully get you better. But maybe a first or second year physio or podiatrist explaining that, it doesn't have as much weight. Like, do you think that's the case, or it purely is just a confidence in the way that you kind of explain it?
Yeah, I don't think experience matters personally. Again, it is challenging, right? So if we look at our patient interviews, they want a diagnosis, right? And patients want to leave a consultation with a diagnosis, knowing what the problem is and what they're going to do about it. But a lot of our diagnostic terms, I think, struggle for relevance. I always use the example of back pain. We want to avoid saying, we don't want to say lumbago, we don't want to say discitis, we don't want to say slip disc, all of these things that we know aren't particularly active representations. So you say to a patient, okay, my diagnosis is back pain. They often say, well, I know that, dickhead. I came in and the first thing I told you was that I've got back pain, right? I got there. Surely you need to be better. So it is that, what's important is that process of ruling out other things. So if we think about the anterior knee, so I explain it as anterior knee pain is the umbrella, and underneath that umbrella, we've got these sub-diagnoses. We want to do, if we're thinking about patellofemoral pain, we want to rule out the tendon. So we can say to a patient, I'm confident that your patella tendon isn't involved. You don't have patellar tendinopathy or tendinitis. I find patients don't know what tendinopathy is, but they know what tendinitis is. And even though we don't like to use that term, patients do, right? So we need to go with what patients want. We know you can have isolated fat pad pain. To the best of my ability, this isn't fat pad pain. Your knee isn't sore when you go into extension. You're not hypermobile. You don't describe inflammatory symptoms, etc., etc. I'm confident that it's not your actual knee joint, the hinge joint formed by your thigh bone and your shin bone. There's no suggestion that your pain is coming from there. We're starting to go a little bit further away from anterior, but if you think about iliotibial band pain and retropatellar bursitis and some of these more common things, if we can get rid of all of those, then patellofemoral pain is what's left. So I think that's the important bit of information. And then when you say it's not this, it's not this, it's not that, etc., what we've got left is an irritated kneecap. That starts to make sense. And I think that would also work if we think about back pain. I'm confident this isn't anything sinister. You don't have any red flag symptoms. I'm confident that your nerve tissue isn't involved. You don't have radiculopathy or sciatica. Once we rule out the things that we know have a good diagnostic process, what's left is an irritated lower back. And then we can use something very similar. But it is hard.
Did you say previously that we're trying to sort of move away from it, like patellofemoral pain more towards kneecap pain? Is that what you mentioned?
Yeah, that's what patients told us in those interviews. Patellofemoral, they just don't automatically know what it means. So the term that was voted on, or the term that fitted into our diagnostic theme, was kneecap pain.
What's the difference then between like kneecap pain and back pain? Because in my mind, that's how can one be that's okay, but the other's not? Like, I don't know. I feel like patellofemoral pain almost sounds like something, but kneecap pain sounds similar to, that's where your pain is. But I don't know.
Yeah, no, absolutely. And I think semantics. No, not at all. And if you don't explain it well by saying I'm confident it's not your tendon, I'm confident it's not your fat pad, etc., chances are one of the first things they say is I've got pain around my kneecap. So if you then say my diagnosis is kneecap pain, you're on a very similar path, right? So at the same time, I don't think there's anything wrong with saying my diagnosis is patellofemoral pain. In simple language, that means kneecap pain, and then on we go with the conversation. And different things stick better or worse for different patients, right? That's another part of it. You have to find the words that resonate with the patient in front of you.
Yeah, for sure.
What do you think is like the nociceptive tissue? Do we know, really? Is there any way to work that out to then better kind of tailor our treatments to people?
Whether it would lead to treatment tailoring or not, I'm not immediately convinced we've got a good answer for that at the moment. I think if we look at the imaging studies, and there's some really nice work that comes out of Harvard in Boston, and David Felson's done a lot of this nice work, normally part of what's called the MOST cohort, which is the Multicenter Osteoarthritis Initiative. There's a definite link between bone marrow edema, subchondral bone irritation, and patient-reported pain. So I think we can be relatively confident that for most patients, at least, whose pain behaves in a very nociceptive way, chances are it's going to be either the subchondral bone or the synovial tissues. And that also comes out of, whilst it's a very small N-of-1 study, Scott Dye's slightly crazy work where he had his,
I knew this would come up. I'm glad it did.
His brother scope his knee whilst he was wide awake. The most bothersome structures were the synovial lining and the fat pad.
Yeah.
So on a kind of list of three, I think it's subchondral bone, synovial lining, and fat pad.
Yeah.
If we've got true nociceptive symptoms, synovial lining, fat pad, they're so intertwined that I don't know if you've ever seen a fat pad dissected from a knee, but it's huge. It's this whopping great horseshoe sort of shape structure. We kind of look at an anatomy textbook or look at a knee and think it's like two little marshmallows at the front that sit either side of the patella tendon. It's way bigger than that, and it envelops and blends with the synovial lining. Whilst kind of isolated fat pad pain is quite extension dominant, and we'd expect people to get symptoms with prolonged standing, walking, hyperextension, etc., not stuff that we expect to aggravate patellofemoral pain, I still suspect there's strong involvement in the fat pad and the synovial lining in someone that gets flexion dominant pain as well.
Yeah. So if say someone does diagnose patellofemoral pain, like in that scenario, if it's bone versus the fat pad, would you then consider like the diagnosis in that setting would matter because a fat pad being highly innervated might respond more positively to, say, a corticosteroid injection, whereas an osteochondral bone, it might be chondrotoxic. I'm assuming, cortisone is chondrotoxic, so you wouldn't want to be injecting around there. So in those cases, does it matter?
I think, and unless there's a clear target on scan for corticosteroid, I don't think we should be using that for people with PFP. Now, don't get me wrong, if someone has very active bone marrow edema, inflamed subchondral bone, if someone has really clear joint synovitis, if we've clearly got a very hypertrophic and angry fat pad, injecting that type of knee with steroid, I think is fine because there's something for the steroid to act on. If someone's not responding to good quality conservative care, bunging steroid in as a hit and hope when there isn't a treatment target on scan is pretty poor practice.
Yeah, because I think like my journey over the years were when I first graduated, I was very biomedical. Diagnosis is everything. I need to tell them the exact fiber that's sore. And then as everyone does, you learn about explained pain, and then you're kind of like, great, diagnoses don't matter at all. You just got pain here. Let's draw some peripheral nerves and give you some pain education. And then you come back into the middle where I am now, kind of valuing both sides. But the common saying like, the diagnosis doesn't matter. It's plantar heel pain, non-specific lower back pain, but you still need to do a really thorough assessment to work out the aggravators, what aggravates it, what eases it, and have somewhat of a working diagnosis, even though you're telling them it is, kneecap pain or patellofemoral pain, because it can potentially bring treatment in a little bit earlier rather than later.
Yeah, and ultimately, another thing we say regularly is whilst diagnosis is important and patients want one, we often don't treat a diagnosis, we then treat objective findings, right? So I do think they're intertwined, and the example I often give is if you misdiagnose patellofemoral pain as patellar tendinopathy, and the first thing you offer someone is a heavy, slow Kongsgaard program through a full range of motion, it may help, but I'd bet a reasonable sum of money that if you give that to 10 patients, at least half of them won't respond, right? And I like to think we can be better than that. By the same extension, if you misdiagnose patellar tendinopathy as patellofemoral pain and you say, right, we're going to start up at the hip and we're going to take the load away from the knee, that person's probably not going to respond that well either, right? So I doubt these things look different from a treatment perspective right at the end, right at the kind of return to sport, return to function juncture. But early on, I suspect they do look quite different. You know, someone that's got a very sore, irritable knee day to day, you think it's PFP and it's actually tendinopathy, and you give someone orthoses, chances are they aren't going to respond. Whereas, you know, someone with a very irritable patellofemoral joint pain day to day, they've got a really good shot at responding well to orthoses. So I think it matters from a treatment direction perspective early on in the journey, not so much towards the end. But what you also said resonated as well, is that patellofemoral pain is often persistent, right? We see people in clinic and they've had pain for 3 months, 6 months, 3 years, etc., etc. Not unusual for them to demonstrate some form of nociplastic change, peripherally mediated symptoms, and then that needs to be managed differently as well.
Mm-hmm. And so, like, what do you actually think changes on like a physiological or biochemical level, given that we're not entirely sure, but we've got some ideas of what might be driving nociception? What do you think changes on a physiological level or biochemical level that moves someone from pain to no pain, whether it be more in that shorter term sufferer or someone who's been experiencing this for quite a long time?
Yeah, I think that's such a lovely question, but also such a difficult question to answer at the same time. And I normally start by answering it by saying that we struggle with this as physios or as allied health professionals because we design randomized controlled trials the wrong way around, right? If you want to test a drug, the very first thing you need to know is the mechanism of action. You need to know exactly what those chemical compounds are going to do to a human system. Once you know that, you make sure it doesn't kill laboratory animals, if we put the ethics aside for a while. Then you do a first in human, and then you do the efficacy trial. Whereas in our field, because the chance of anything that we do being particularly harmful or negative consequential, we kind of skip those phases and just run the trial. And then we go, oh, look, this thing works. It's better than doing nothing. And then we come along and say, well, how does it work? How does that change pain? And we all kind of go, no idea, because we do trials the wrong way around. Understanding mechanism of action and moving towards that point of precision medicine, I think, so important. And it's a big part of my research agenda. But we're not at that point right now. So the analogy we often hear is it's load versus capacity, right? And that seesaw model of right now, the load you're placing on your tissues is greater than their capacity to tolerate. So in the short term, we're going to take some load away. We're going to do some stuff which increases your tissue capacity. And then as we start to expose you to more stuff, you'll be more tolerant of it. I think it's a lovely theory, and I think it really resonates with patients. I struggle with it because I don't think we can define what any of those things are. You know, if I ask you how to measure your tissue capacity, I suspect you'd struggle to give me an answer because I've asked several people and they've all struggled as well. So the other challenge is ultimately it's multifactorial, right? So when we teach this stuff to undergrads, we have to think at a very basic level relative to their prior knowledge. So we talk a lot about descending inhibition, right? If we change the input to the system, we may have a positive consequential effect on the output. So I think exercise and orthoses and some other stuff that we do can have that nice descending inhibition mechanism behind it, but exactly how much and how frequently and in whom, etc., then it starts to fall apart, right? Same as the tissue capacity, load capacity model. So chances are we're acting through, our interventions are acting through lots of pathways. And what will really change practice is getting to a point of being able to line patients up that have the same diagnosis on paper and say, well, because I've seen X and Y, you're going to do this. And because in you, I've seen A and B, we're going to do this. But we're just not there yet, unfortunately. We've got some guidance, you know. So in our in our best practice guide, how do we decide when to load at the knee as opposed to when to focus slightly more on the hip? The stuff we can get from patients can guide us there. So if someone's really irritable, really load intolerant, the best will in the world, whatever we ask them to do at the knees, probably going to make them worse in the short term in terms of their pain experience. So let's quieten the knee down. Let's do stuff more proximal. Let's see what happens. Same for orthoses and tape, right? If someone's really symptomatic day to day and they're struggling to do anything active, well, then we need paracetamol for that headache. We need to go passive and see what we can change. But the exact pathways that all these interventions are working through, maybe invite me back in 10, 15 years' time and maybe I'll have a better answer.
We're penciling you
maybe
in
I'll
for
have
15
given up.
years.
Maybe I'll have given up and I'll have given up and started to run a coffee shop by then.
Do you think you would ever go crazy enough? You're like, all right, just open my knee up, get the anesthetic. I'm not using it. Let's just go in and test it out, like Scott did.
Well, I mean, the really tricky thing within the patellofemoral joint is you almost can't do a diagnostic block. You can't block the patellofemoral joint without blocking the tibiofemoral joint. So that's why we haven't got good local anesthetic block studies in the knee, because it's really difficult. And that one of the drawbacks of Scott Dyer's study, whilst I commend him for letting someone scope his knee whilst he was wide awake, the one tissue they couldn't get at was the subchondral bone, right? Because he's not going to actively create a defect in his knee in order to get down to that subchondral level. So we don't know that bit either. So that is part of the challenge. And if we could get to a point of doing some of that, it would be helpful. There are a couple of studies that have looked at, there's one very unusual trial that made it into our best practice guide that looked at a sclerosing injection to the genicular branch of the femoral nerve combined with exercise, and that seemed to be useful. But I've never seen that intervention actually delivered in practice anywhere around the world. Doesn't matter who I've spoken to. So that's in there, that perineural dextrose, that's the word I'm looking for. It's in there, but with the acceptance that I don't think anyone's out there actually doing that.
Yeah. And I've heard you mention this, and I finally got a hold of the paper today, and I also read another paper that the 50% of people with PFP still have pain between 5 to 8 years, and a study of 250 athletes, it was like 36.6% still had pain or worse. And maybe I'll tag that. I've got both papers on my computer, so I'll put them in the show notes. But basically, the summary of both of them is people had pain for a long time. Like, does that surprise you? I mean, 50% at 5 years, that's a long time, and that's a huge amount of people.
Yeah, I don't think it does surprise me that the more I think about it, like the common message around patellofemoral pain or anterior knee pain, I'll think very clearly about the UK lens at the moment. Most people still go to see their GP as first point of call, right? And they're often told this is a self-limiting condition and within 12 weeks, you'll be doing well, right? And we know that's not the case. They then end up at the door of a physiotherapist. So they've already had symptoms for, let's be positive and say 3 months before they then see a physiotherapist or a podiatrist. It's also then common for that message to be repeated. Your symptoms don't appear to be self-limiting. We're going to do some stuff, but I still expect you to be doing really well in 12 weeks' time. Again, the literature just doesn't back that up, right? So we're now at 6 months and the patient has been told, well, I was told this would go away on its own and it hasn't. And then I was told it'd go away with doing some stuff and it hasn't. So we're 6 months in, So we know that patellofemoral pain isn't self-limiting. We know that its treatment course is prolonged. And yet, as clinicians, people are often out there saying this will go away within 3 months or 12 weeks. So we almost set patients up for failure, right, in that early phase. And then not only that, what came out really clearly within the systematic review component of our best practice guide is of the 170 trials that we found, we put 105 in the bin because the quality's too poor. And then of the 65 that we retained, only one intervention, and it was actually orthoses, were tested beyond short-term follow-up. So we've got lots of fairly poor quality trials, and the good ones that we've got don't follow patients for a very long period of time. So we're really lacking high quality long-term trials that guide practice. So when we put all of that together, it maybe doesn't surprise me that the prognosis at the moment appears to be so poor. I quite often used to say to patients with tendinopathy, this will get better over months and not weeks, and sometimes years and not months. And I'm ever more convinced that we should be saying something very similar to people with patellofemoral pain. And it's not that you won't be doing stuff by 12 weeks, but the expectation that your symptoms will be completely resolved is completely folly.
Yeah. And do you think there are any factors you've identified, even, previously when you're in your clinical practice, anything that you see, if someone comes in and they had pain for a long time, I mean, it's common in most musculoskeletal conditions, but things like catastrophizing, kinesiophobia, I think there's a subgroup of people that have some of these things, whether it be alignment or biomechanics or all of those things, where you think they're probably going to be a bit more likely to suffer for a longer time. And in those cases where that does happen, treating it really similar to a tendinopathy, where you're saying, we'll try our best to get it as best we can, but let's not put your life on hold for that. Let's try and get you back to doing what you can with manageable pain, and then, hopefully to no discomfort.
Yeah, it's not that different to any other persistent musculoskeletal condition, really. So I've got a fantastic full-time Ph.D. student at the moment, and his first project, which is under review right now, was a meta-regression looking at both prognostic and mechanistic variables in patellofemoral pain that came from all those high-quality trials. Symptom duration's a big predictor. So the longer you've had symptoms, the poorer your potential for response. That probably doesn't surprise anybody. Age is another one. So the older you are, the greater the potential for your response to be poor. Height, interestingly, the taller patients do worse. I haven't got a good explanation for that one. I haven't got a good explanation for that one at the moment, outside of kind of really putting on my biomechanist cap and thinking about lever length and joint forces and stuff. There's a little bit of stuff around muscle strength at baseline. So the longer you've had symptoms, the more chance there is that you'll have significant muscle weakness, the poorer your potential for response. And there's a couple of other reviews from a few years ago that say very similar things. There's a little bit of stuff around joint structure. So the more dysplastic your joint, so things like patella alta, tibial tubercle trochlear groove distance, trochlear depth, all these things have a pretty significant association with advanced joint change. So I think off the top of my head, the odds ratio for patella alta and fat pad synovitis is something like 25. So if you've got a high riding patella, you're 25 times more likely to have inflammatory change in your knee. And it then goes up for a laterally displaced patella and a shallow trochlea as well. So some of these structural markers seem to matter. And that's why I get a bit perturbed when I hear people saying you don't need to scan patients. I think you do. You just need to scan them for different reasons than what people typically think. If I see someone and we've scanned them and they've got a dysplastic joint, I will always tell them your joint is going to be slower and more irritable. And we're going to have to be really slow, really step by step. Normally I would say to people, I'd expect you to be doing better than you are currently by 12 weeks. And then hopefully doing significantly better by 6 months. We're going to double that time frame for you because you've been given a joint that's different to what a textbook tells us it should be.
Yeah, it's really interesting to hear you say that, because we just did a podcast on navicular stress fractures, and we were talking about, some people just anatomical variation, then navicular has better blood supply than others, and obviously we can't change that. And as soon as you said that, the first thing I think of people just saying, anatomy doesn't matter, who cares, we can't change it. But there are some cases where we probably do need to be forthcoming with the people that we're seeing, whether they do get a scan, and saying, hey, this anatomical variation, this is likely what it does mean for you, and this is the reality of it. Is that the kind of conversation that you're having, and just saying, this is going to take a little bit longer, or potentially we need to bring other interventions in sooner, or maybe we get a surgical opinion sooner, those types of things, like just saying this is how it is?
Yeah, my common line is, I can't change your structure. And if I ask a surgeon to change your structure, it probably won't go well. But we can accept and respect your structure and accept that it's going to slow down your journey. It's things like that patients need to hear. But yeah, we kind of swing around, don't we, in our field? This matters, that matters. I'm at the point where I'm comfortable everything matters, that the skill is knowing what matters for the particular person in front of you during any particular consultation, right? The other challenge we have in our field is that we've got lots of evidence that conflicts. We haven't really got any, there's very little things on our list of definitely shouldn't do, right? I think that's one of the other challenges. So when people, why does therapeutic ultrasound persist in practice? Why do people continue to express that they can reliably and accurately palpate the spinous process of L5 relative to L4? It's like, well, I get why these things exist, because there isn't any hard, fast evidence that says they're harmful, right? Like if you were to really sit down and be judicious about stuff that we definitely shouldn't do, I think the list would be pretty short, right? Like, I'll use dry needling as an example. I did acupuncture dry needling fairly early on in my career, did a bit of it for a while.
So did
actually, my first ever published paper was actually a theoretical piece on acupuncture for tendinopathy. It's been cited a fairly reasonable number of times. But I'm at the point in my journey where I don't think needling offers patients anything, right? But is it dangerous? Well, yeah, if you needle around the shoulder and the neck, you might cause a pneumothorax. So that's probably not sensible. You need to be slightly careful around the lower back, maybe in terms of kidneys and stuff. But ultimately, sticking needles in other places, it might not help, but it's probably not going to hurt either, right? There's very limited potential for harm. So I think that's why these things persist. And back to the evidence question, we definitely aren't in a situation where we don't have enough evidence. We've got too much evidence, and 95% of it's crap. So it's about filtering out and finding what should genuinely change your practice, as opposed to small things. And I know it's really easy for me to be critical, right? Because I don't see patients day to day to make my living anymore. But there's a trial in the patellofemoral pain field that looks at mindfulness and recreational runners with patellofemoral pain. Now, for stress and anxiety and stuff, I'm a big personal advocate of mindfulness. I think these things can be really useful. But I see people banging on about that trial as if it's definitely something we should be doing. There's 12 people in each arm or something. It tells me nothing. Like, it should just go in the bin along with all the other really crappy trials that shouldn't change your practice, but people latch on to the thing that they like the sound of, right?
Yeah. I love the reply, not to single in on dry needling, but when people are critical of like, oh no, you just don't know how to do it properly. Come to my course. My course is the one. I'll show you how to do it. It works, trust me. That's always the reply. And don't even bother.
You look at our best practice guides. There's evidence that dry needling is no better than sham needling. Kind of the needles that recoil up into the tube when you tap on them. And there's evidence that dry needling and exercise is no better than exercise alone. So, purely for patellofemoral pain, which is what that study looks at, I think you're on really shaky ground if you want to use dry needling with people. The evidence just really isn't there.
Mm. Now, this is the big question.
We've had lengthy discussions about this.
Yeah, I slept out on the lounge the other night because we got into a big argument over this question. No, kidding. We were driving to the airport last week, and it was a 35-minute trip. And Kelly was very glad I was getting on that plane because we were in hot debate, which is basically the reason how this podcast started. What we were talking about is my argument and my theory and thinking is, let's just say it is around the patellofemoral joint, and we have a runner, and it's kneecap related pain. We can say that the structures, I think it's the wrong word, but I hope you get what I mean. I'm saying that they're kind of involuntary. Like, you can't contract the joint, you can contract the muscle if load the joint. But truly, if we're saying it's a matter of the loading cycles have exceeded what the knee can tolerate. Like, if you can run 5 kilometers and your knee's okay, and you run 10 kilometers, the loading cycle have exceeded what it can handle. And that probably has happened over time. So when it comes to hip and knee loading versus doing this quality return to run program, can we not just dose someone with the activity that they enjoy and not worry about the exercise if it's purely related to the joint? And let's just say they don't have a deficit. Can I just say, well, you can run 500 meters until you get maybe a 1 or a 2. Let's just do 4 sets of 400 meters, rest for a minute, and I'm just going to dose you with that. And then I was trying to look to the literature to see if any individualized running program has been compared to hip and knee loading, find anything. So that's what we're arguing about. Why can't you just dose them with their activity? based on where that person is.
Whilst I am married to a physio, I'm not married to a musculoskeletal physio, so we very rarely talk about work. That's probably how our marriage has survived, so maybe that's a bit of backhanded advice for you both. I think there's plausibility, right? So I think that would be on the list of things that hasn't been tested, but I think there's plausibility, right? We obsess over muscle function, muscle deficits, and I think physios are particularly guilty of this. You know, we have the whole "you can't go wrong getting strong" mantra, and I think for kind of overall health, I think that's true. For musculoskeletal pain and function, I don't buy into that personally. What is strong enough? Do we compare one side to the other? You know, is there a normative value we should be working towards? There's so many unanswered questions. And I think the mechanism of action from, let's say, resistance-based exercise is more than changing strength, right? We don't know what it is, but it's likely to be multifactorial and run down multiple different pipelines. So I do think for certain runners, it may well be that if we just strip them back to very, very little and then build them at a pace that works for the irritability of their joint, that may get them there, right? There's a trial in my, very small trial in my Ph.D. that looked at step rate retraining in people with patellofemoral pain. And one of the things we did as part of that trial is we increased someone's baseline step rate by 7.5% using a metronome. But the other thing we did is put them through a 6-week phased return to run program involving 3 runs per week, where you gradually spend more time on the treadmill and less time walking. We looked at kinematics, we looked at EMG, we looked at pain and function, and loads of stuff changed, different magnitudes for different people. So you could reason that as, you know, we've definitely changed the load exposure through the joint by manipulating step rate, by manipulating kinematics, or you could say I've just built someone up super slowly from 0 to where their number needs to be. And I think both of those arguments are likely to be valid. We just don't yet know what would be best for any one person to do. I feel like I'm giving you an answer I've already given you, so I'm going to stop. But I do think there's plausibility that for and running's a nice example, right? Because it's a repetitive action that some people might just need to be stripped back to the bare minimum and built from the ground up super slow.
Yeah. And do you think, I'll just change a bit of topic to bone stress injuries. You know, when someone has a bone stress injury, you know, we know their bones get a little bit weaker and smaller. They need to build back bone mineral density by generally doing high quality resistance training and doing it consistently, because bone takes a long time. Do you think that people with patellofemoral pain, or generally most people, and it's a safe bet, that they just continue to do resistance training for their muscle and tendon health, which inevitably is going to affect their joint health? Like, does having a stronger muscle protect the joint more? Is there some other mechanistic action that we're not aware of that by loading the muscles, it is just better for joint health?
Yeah, again, I think it's a lovely question that the answers to which are likely to be somewhat opaque. I think you can argue it either way, right? So if you look at let's look at the quadriceps, right? Let's try and think straightforward. And we have someone with patellofemoral pain, and we increase the strength and force output within their quadriceps. Well, what does that do to their patellofemoral joint? Well, in theory, it will increase the congruence of the patellofemoral joint. It will lead to better connectivity between the patella and the trochlea, but it will also increase patellofemoral reaction force, because muscle forces are part of overall joint forces that go into a good joint stress model. So that might leave you in a net neutral position, right? And the increased reaction force is mitigated by the increased congruence. So the more I think about it, whilst I love biomechanics and have lots of very expensive biomechanics kit in my lab and love playing with these toys, every kind of year that passes, I think these things probably matter just that little bit less. And I suspect the benefits that are derived through resistance training are likely to be away from the realm of biomechanics. So if we think about bone loading, you know, we know that bone responds positively to external load, providing we get the dosage right. What's the correct dosage for any one person that sits in front of you? You might as well lick your finger and stick it in the air, because we're all guessing ultimately, and we're therefore guided by patient-reported symptoms, right? And, you know, you can get really technical and go, well, we know that bone turnover takes approximately 12 hours, so we want at least 12 hours between loading cycles and or you could just listen to what patients say. And what I used to say to patients clinically is, if we're doing a return to run program, whether there's a run retraining component to it or not, is I don't want you to wake up with a hangover. So we're going to do 3 runs a week, and here's your program, and here's what we're going to stick to. I don't want you to run on consecutive days because you don't need to, but I do want you to wake up feeling like you could if you had to, right? I don't want you to wake up thinking, oh, I feel a bit dusty. I know I went for a run yesterday. I want you to wake up thinking, yeah, if I needed to, I could, but I'm not going to. And then we do it again the next day. And if you avoid that symptom hangover, that's probably the best tool we've got at the moment of managing how someone is responding to whatever we're asking them to do.
Nothing gets me going better on a Wednesday night than a good analogy. Are you like tending to talk to us the next day? Don't wake up with a hangover. That's so good. That's awesome.
I mean, and the hangover analogy generally lands well with Aussies because you all like a beer, right?
Good beer, that is.
I mean, as do I, obviously. But I think it works regardless of the pathology, right? It doesn't matter whether you're talking about someone with back pain or a bone stress injury or radiculopathy or whatever it is. You know, I think radiculopathy is a really nice example, you know, and I can hopefully speak pretty well to this because I had a nasty cervical radiculopathy 5-6 years ago. What did I needed to do? I needed to stop pissing it off. Like all the stuff I was mucking around with doing and exercises and manual therapy and stuff. It was just desperate to be left alone, let the nerve calm down, and then over time restore function. And you know, you keep poking the bear, eventually the bear's going to bite you. And I don't think the tissue or the diagnosis necessarily matters.
Yeah. Do you think the kind of, I say recent, but I guess I'm more of a recent clinician, the idea that pain neuroscience education, you know, it is going to be the thing to help people with their pain. You know, it was thought, yep, you tell someone this, their pain just goes away. You know, it's much more than that. It's helping them understand what's happening to them and helping them be able to better manage their pain throughout their life. Do you think that has a place with patellofemoral pain? I guess there's versions of this, but do you think it is superior to giving that kind of pathoanatomical explanation? Like, are there any risks associated with that? People maybe not engage in activity or they get worried when it gets painful?
Yeah, I think pain neuroscience is a really nice example of, and we do this so much in our field, right? Someone comes along and goes, I've got this new thing. And we all go, ooh, and they test it in a really perfectly controlled trial and it looks amazing. And then someone else comes along and goes, let me play with that. Didn't work that well for me. And over time, we end up kind of getting washed out to the point where it maybe does a little bit, but not a lot. You know, look at exercise for osteoarthritis, Mel Holden's lovely individual participant data meta-analysis. The net change on an MPRS score at 12 months with exercise is 1.1 points or something. Like you can easily look at that and go, exercise is pants. Let's stop doing it, right? Yeah. Within that cluster, there'll be people that did amazingly and people that did kind of averagely and people that did terribly. And being able to sift through that will get us where we need to be. Education, I think, is an intrinsic part of what we do, regardless, again, of the diagnosis and of the patient. That came out really strongly within our best practice guide. Education's not been tested as a standalone intervention in patellofemoral pain, but interviews with patients, interviews with clinical experts, the focus groups that we did with clinical experts, they all spoke about education as being intertwined with everything that we do. So if you're going to prescribe an exercise program, if you're going to prescribe orthoses, if you're going to tape someone's knee, if you're going to ask them to build their running slowly but surely, we need to explain why we're doing it, why we think it's likely to help, what we're going to do if after a certain time point things aren't responding as we would expect, and we're going to pull back. It's just an intrinsic part of what we do. We are testing it at the moment, actually. So we've got a £100,000 grant from the Chartered Society of Physiotherapy's postdoctoral research fund. We're running a relatively small trial in the NHS at the moment, looking at testing an online education intervention compared to staying on a waiting list. So half the participants are going to be randomized to just staying on the waiting list. Half of them are going to get access to this online platform that's designed to teach them about their patellofemoral pain. And ultimately, it goes through a couple of sections, but the kind of message of the education intervention is, this is what we think patellofemoral pain is. It's unlikely to be damage to your joint. It's more likely to be irritation of your tissues. If we can take away the sources of irritation slowly but surely, you'll get to where you need to go. There's a bit of information around dosage and avoiding provocative activities. There's some stuff about starting to exercise and perform resistance exercise if you want to. whilst it's what we call a feasibility trial, so it's designed to inform the big kind of whopper trial that we plan to do in a couple of years' time, providing it proves to be feasible. But we anticipate that it might get people off a waiting list. If you think about that relatively high-functioning person that gets referred, they get access to this information and they conceptualize it as, okay, I don't need to worry about this. If I stop annoying my knee, move a bit slower, do a bit of this, we hypothesize that a good number of them will get to their turn to see a clinician and go, no, actually, I think I'm all right now, And part of the reason we can run the trial is the NHS trust that we're doing it in has got a waiting list at the moment of 17 weeks. So it's a good chunky waiting list that actually allows us to run the trial. And then, down the line, if it does prove to be feasible and then we run the big trial and it proves to be effective, well, then hopefully we can get waiting lists down by getting rid of the high-functioning folk that just need the right info to get on with their life.
Yeah. There's your 5-year, 50% mark there, 17 weeks.
17 weeks, absolutely, right? Absolutely. I would say to students with a waiting list like that, you're either broken or better by the time you get in front of someone.
Yeah.
Or if you want me to be a bit more blue, you're fixed or you're fucked. There's no in between, really.
And you'd fit right in over here. I think I could see you down the street.
I've spent enough time in Australia to fit right in. Don't you worry.
I don't know if you can say or not. Is the education that they're getting, is that via video or are they reading or what's the kind of way they're taking
a big mix.
Information?
So it's an online platform. There is some text, there's some video, there's some audio, there's a real mixture. Some of it comes from Christian's Trek initiative, some of the videos he created early on with Michael Rathleff and Danilo Di Oliveira Silva, who's a collaborator on the project. So it's a real mixed bag. It's all online, but it's a mixture of written info, audio, visual, like cartoons, exercise videos and stuff. It's offline. It's behind a password at the moment because we need to make sure the people randomized to the waiting list don't accidentally find it by Googling patellofemoral pain stuff. But offline, I can give you the password if you want to take a look, because up until recently, it's just been freely available on our website. But now that we're using it in the trial, we've had to lock it behind a password, but I'm happy for you guys to have a look at it.
Yeah, that would be awesome.
I love hearing stuff like that.
As long as you don't share the password anywhere.
Of course.
You just see it in the Herald or something like that. Free information.
I love hearing stuff like that where it's just so like clinically relevant and it's actually going to make such a big difference. Like as you said, there's so much research that's essentially just waste or junk. But then you hear about things like that and you're like, wow, these things are actually going to make such a big difference within the community. It's nice to hear that, yeah, that's happening.
Yeah, and I think some clinicians panic about it. They can't go, well, what if reading a website is all people need to get better? And it's like, well, it's not going to get everyone better. It's going to get some people better, hopefully. And then it will give you earlier access and more time to spend with the people that actually need to be in your clinic room, as opposed to people that might just need the right steer, So I know it's easy for me to say that because I don't treat patients day to day to make my living at the moment. But I don't think we should worry about education as a standalone being so effective, because it will just give you more time to spend with other patients that do need more than that. And there's plenty of people out there.
Yeah, I can see that argument for both. I mean, ever since we started the podcast and socials, I'm maybe just more acutely aware, but I find maybe it's just a cohort that I'm seeing. The people are coming in with a higher health literacy. They've got a good understanding of foot orthoses and shoes or running. They're like, yeah, my knee's sore. Done a little bit of Googling. I think this is what it could be. And I think I just need someone to kind of guide me where I need to go, which I need to do a little bit of this. I need, I think, a running plan. And, on the contrary, there's other people that come in and say, I think I've got a stress fracture in my knee. What do I do? They've done some Googling. But I think, I don't know, would you agree that on a whole, probably having more information is better for society to better understand? Like you said, there's people that can self-manage. And when they come in to see us, potentially they're like, oh yeah, I've read that. That's true. I need to do that. But I guess it's only true if they've read the right thing.
Yeah, it's whether the message sticks, right? I think that's the key, right? Like, do people respond differently to me compared to some colleagues because sometimes you get to call me doctor? Maybe. Do people listen to orthopedic surgeons more than they listen to physios? Probably, because there's societal value attached to a surgeon, or so different messages stick better with different people. And I think the same is true for clinicians, right? Like I'd love to sit here and say everyone's out there reading our best practice guide because it's open access in BGSM, but The reality is you all learn slightly differently, and that's why I like doing these podcasts and come around to blogs and social media and stuff like that. More mediums we have to translate knowledge, the better. And I think that's true for clinicians, but it's also true for patients as well. But we do know is that a pamphlet that comes off a rack in the clinic room that's been sat there gathering dust probably isn't going to do the job, right? There needs to be an element of interaction with education, and that may not need to be face to face, but the reasons that we think this education platform that we've built will land is because we've got so many different mediums on it, but it's also interactive in that there's a quiz at the end and you have to answer questions, and allows us to test retention of knowledge and stuff. So I think it'll land because it is interactive.
Yeah. I've got a couple of final questions to finish with. We both see it and work with lots of runners. Kelly obviously sees more patellofemoral pain than I do. Being a podiatrist, I'm a bit smarter, obviously being below the knee. But that was a joke if listeners were wondering. I'm being sarcastic. With your running, like return to run program, and there's some great examples out there, but do you ever typically, or do you recommend, or is there any research on like uphill programs or modifying some things so people can have a better return to running? Or are you just saying keep it flat, keep it easy, use these symptoms to guide you, don't wake up with a hangover and progress over that time?
I think if you're gonna do any form of run retraining, so if we've decided that we want to try and manipulate something through a mechanics lens, that needs to be done on the treadmill. So that's one of the drawbacks with step rate retraining. If you don't do it at a fixed constant speed, all that typically happens is that people run faster. So early on, at least, needs to happen on a treadmill. And I don't know about you guys, but most runners that I see are a bit resistant to running on the treadmill, but you can normally convince them short term it's going to be the thing that gets them there. Ideal world, if we're doing that kind of gradual approach, flat as possible makes sense, right? But the world isn't flat. It is the reality. Even if you live in Holland, it's still the odd hill here and there, right? So know that running uphill is probably more tolerable than running downhill for the average person, because running uphill you kind of naturally shorten your stride length and manipulate your contact time is the sort of thought process, whereas running downhill, people typically lean back and use their leg as a brake, and we know that is a position of a joint load. So I think you can use these things to your advantage, but again, I'm starting to sound a little bit like a broken record, but you've got to work with what you've got in front of you, right? And if someone doesn't have access to a treadmill, or flat out refuses to run on a treadmill, or lives in an area that's super hilly, you got to defy it to the best of your ability.
Yeah. And would you say that this is what I would typically do with someone that hasn't run for a while? We would just jump up on the treadmill and we'll watch them run for a minute. We do a running assessment in quotation marks, which most of the time I just tell them, hey, it's fine, let's just start running. The real reason I'm doing it is, just want to make sure things aren't too different or something's not grossly asymmetrical and related to their condition. But I'm like, great, you just ran for a minute. How were the pain levels? Like, yeah, that was fine. Like, awesome. How would you feel with just starting with a couple of minutes of running and a couple of minutes of walking? Do you find that's kind of a way to approach it? Show them the proof of safety, show them they can do it. I'm assessing them there and get them, if they can tolerate a minute, I'm going to be pretty confident they can tolerate 4 of those. And then we've just got somewhere to start from.
Yeah, so the protocol we tested at my Ph.D, week 1 was minute on, minute off by 10. So 10 minutes of running, 10 minutes of walking. The instruction was a conversational pace, so you should be able to keep talking to me during the run increments, depending on who people were. Blokes are generally a bit worse than women. They always tend to run faster than they should because they want to show off. Yeah, I find, and then week 2 is 2 minutes on, 1 minute off times 8, and it builds from there, and I find run walk is a nice way to go. It lands well if someone hasn't run for a long time. If someone's kind of banging their head against a brick wall, still knocking out 3-4 runs a week, kind of, 20, 30, 40K or whatever, they're generally more resistant to stripping it right back to that sort of program. But yeah, I think it's a good way to go. And it often makes sense to do that on the treadmill because, if you minute on, minute off times 10, running outside, you may not have a loop that you don't know exactly how far you're going to run, etc. Whereas on the treadmill, everything's controlled.
Yeah.
Now, last final question, and it's just a quick fire question for you. If you could conduct any kind of research, there's ethics don't exist, funding is unlimited. What sort of research would you be looking at?
personnel, everything. You can do whatever that you
Money,
want to do.
no object. He is a big object in research, unfortunately. I think my answer is probably going to be a bit boring, really. We need to do a big randomized control trial. We need lots of people in it. We need to run it over at least 12 months so that we look at that long-term output. And, it would make sense to test the interventions we have in that best practice guide, or test the guide relative to usual care. And then real world, I would collect variety of theoretical mechanistic data at multiple time points. And then that would give us the ability to run, we call mediation analyses, to try and explore if the outcome experienced by people receiving an intervention is explained by changing in a variable. Mediation analyses are often done post hoc. So ideal world, you do it a priori, so you know exactly how many people you need, not just to test the effect of the intervention, but also to run the mediation analysis. And, ideal world, you're going to have 200, 250 people in each arm in order to really get at that question, which is the challenge.
Wow. How many people do you think you'd need for that? Like over 1,000? Couple of thousand?
It depends how many interventions you're testing. Whilst it's easy for me to sit here and say, we have too many trials that are short term, not enough people in them, et cetera, it's really hard to run a trial over a long enough period of time with enough people in it without losing them, etc.
So if you could interview anyone, dead or alive, and to give you some context, we've had people say Donald Trump, Nelson Mandela,
David
Attenborough. And no one said anyone medical yet, but so you don't have no pressure. But if you could interview or talk to anyone dead or alive, who would it be? Anyone at all? Long format conversation. Just you, a couple of coffees, and them.
Good question. Who would I go for? Said he wouldn't be Donald Trump. I can tell you that much.
Yeah, we were very surprised. I can't remember who said that, but it was surprising.
I suppose he probably would be a relatively interesting dinner guest, wouldn't he? If for no other reason than he's probably about as mad as a box of frogs.
Would it be medical? Or would it be someone...
God,
like, no.
God, no. Definitely not. Obvious answer for me would have to be Kurt Cobain.
Okay.
Big grunge kid growing up, loved Nirvana. Would definitely like to sit down with Kurt and ask him a few questions. He'd be on the list. I think the other one would be Jackie Robinson. You probably won't know. So Jackie Robinson was the first black player to play Major League Baseball. Went on to do kind of all sorts of good charitable stuff. So film 42 is a really good watch, starring the late Chadwick Boseman as Jackie Robinson. Harrison Ford's in it as well. Yeah, just to kind of the insight into growing up, particularly during the Second World War, and being black and fighting for your country, and then coming home and being told because you're black you can't do certain things, you're not allowed to be a professional athlete, etc. Hearing about what he went through and how he put up with it, and he'd be high on the list, I think.
That's super interesting. Yeah, good answer.
Yeah.
Great answer.
And for people to find you, and we'll have everything referenced down in the show notes, what's coming up? I know you both have run some courses. Obviously, there's socials, you're doing research. Do you have anything upcoming in 2025 or online, in person?
Yeah, we've got some courses next year. We generally do kind of 4 or 5 a year. I've got one in, we actually don't run that many in the UK, but we have got a UK course in March, details of which are coming out soon. Yeah.
In Australia?
Oh, we haven't done. Well, I haven't taught one in Australia for a while. The last course I did in Australia was back in 2017. So it's been a while.
Time.
It might be time. Got a great place here next to the beach. Good coffee.
Yeah, I'm not averse to it for sure. It's a slightly long flight.
Yes, flight's horrible.
No, I keep saying I need to get back to Oz. I've got lots of good friends out in Australia and haven't been for a few years, so do need to get back. And running a course is often a good way to finance the flight and bring the family, etc. It probably won't be next year because we whether this will be good or not, I'll let you know. But we're taking the kids to Disneyland next year for the first time, which is up just to the summer. But maybe 2026.
2026.
We can come back to Oz and do a course, and Yeah, other than that, we've got our website, which is teampfp.com. Instagram, we are Team PFP. Twitter, I'm Dr. Brad Neal, although I use Twitter less and less these days because it just becomes more and more of a cesspit with every week that passes, I think. But Instagram's the place we're most active in terms of socials, but I must admit we don't do that much because it rarely gets high enough up on my weekly priority list to make something happen. But
So you're not spending too many hours a week engaging in some lovely Twitter storms back and back.
I've been there, done that.
There's so much. Like my whole feed is just health professionals saying you're wrong, I'm right, or some study that comes out. Like I knew this was the case, and then everyone just debates, and it goes on forever. It's crazy. It's a lot of time it gets wasted on that platform.
Yeah, loads. Nah, been there, done that. Got the t-shirt. Don't find any great value in it anymore.
Made the grand final.
Yeah, made the grand final. Hopefully won, but yeah, it's not my bag anymore. There's way more useful things you can do with your time than worrying about social media, I think. Don't get me wrong, it's a good, it can be a really good resource for knowledge sharing, and for all of its flaws, it could work. I still think Twitter's where it's going to work because I like that long form. It gives you the ability to explain and link and stuff, whilst Instagram's really visual and good for other things. It's hard to kind of link to your sources and stuff on Instagram, I think, which is one of my challenges with it. But
yeah, you just don't need sources. Just say whatever you want. Like, the references
whatever you want. Later. Yeah, I'm right, you're wrong.
Like, just come to me in a dream.
Thank you so much, though, Brad. We really enjoyed this conversation. I got heaps out of it, and thank you for dedicating 90 minutes out of your Wednesday morning to chat to us. We really are grateful.
Yeah, just
my pleasure.
To add to that, I mean, this idea in health and wanting to learn and translate knowledge, like none of this is possible without people like yourself. Like it's just unbelievable to think, you've been on multiple podcasts, but that information is so accessible to people, and you've got all the knowledge, and you've been there and done it, and you're sharing it. So we really do appreciate it so much. And I know the listeners will as well.
Oh, thank you. I appreciate you both and appreciate the invite.